Respected Professor Sir, my dear students, I welcome you all for another session of DNP RAISA online activities session today. Today we have theory questions. Without wasting much of your time, I hand over the session to the first speaker, over to Dr. Muthumani.
Sir, good evening, sir.
Good evening. Go ahead.
Yes, sir.
Are you able to hear me?
Yes, sir. Able to hear, sir.
Okay. Yeah,
Yes, sir.
go ahead.
Sir, my question is
You have
define
enough
shock.
time to prepare your answer. You last class you said you don't have time. Now you have had more than your quota. Go ahead.
Yes, sir. Shall I start, sir?
Yeah, please.
Yes, sir. Shock is a syndrome characterized by decreased perfusion of a tissue, leading to decreased supply of oxygen and nutrition to the cell, associated with hemodynamic instability, leading to cellular dysfunction, organ failure, and death. Types of shock: distributive shock, which is characterized by peripheral vasodilation, and it includes septic shock, anaphylactic shock, neurogenic shock, and endocrine shock. Second one, hypovolemic shock, which is characterized by decreased intravascular volume and increased systemic venous assistance. It divided into two broad subtypes such as hemorrhagic hypovolemic shock and non-hemorrhagic hypovolemic shock. Third one is obstructive shock. It is mostly due to extracardiac causes leading to decreased left ventricular cardiac output. And causes of obstructive shock are tension pneumothorax, pericardial tamponade, restrictive cardiomyopathy, and pulmonary embolism. And the last one is cardiogenic shock, which is a primary cardiac disorder characterized by low cardiac output state of circulatory failure that results in end organ hypoperfusion and tissue hypoxia. And the etiologies are acute myocardial ischemia, cardiomyopathies, myocarditis, arrhythmias, severe aortic and mitral valve insufficiencies, right ventricular failure, and aortic dissection. According to shock trial, criteria for diagnosing cardiogenic shock is systolic BP blood pressure less than 90 mm of mercury for greater than 30 minutes, or vasopressor support needed to maintain systolic blood pressure of greater than 90 mm of mercury. And evidence of end organ damage such as urine output less than 30 ml per hour or cool extremities, and cardiac index of less than 2.2 liter per minute per meter square, and pulmonary capillary wedge pressure of greater than 15 mm of mercury. Cardiogenic shock has a higher incidence in following patients such as elderly population, diabetic population, female gender, and prior history of left ventricular injury. Pathophysiology of cardiogenic shock. The primary insult is reduction in myocardial contractility, which leads to diminished cardiac output, hypotension, systemic vasoconstriction, and cardiac ischemia. And the hallmark is peripheral vasoconstriction and vital end organ damage, which stems from ineffective stroke volume and insufficient circulatory compensation. Compensatory peripheral vasoconstriction may initially improve coronary and peripheral perfusion. However, it contributes to increased cardiac afterload that overburdens damaged myocardium. This results in diminished oxygenated blood flow to peripheral tissue and ultimately the heart. Systemic inflammation causes pathological vasodilation, releasing nitric oxide synthase and peroxynitrite, which have cardiotoxic inotropic effects. Interleukins and tumor necrosis alpha factors are additional systemic inflammatory mediators that results in vasodilation and contributes to mortality in patients with cardiogenic shock. Diagnostic evaluation of cardiogenic shock includes the following such as complete blood picture, coagulation profile, arterial blood gas analysis, serum lactate level, N-terminal pro-B-type natriuretic peptide, cardiac enzyme tests, chest X-ray, ECG, two-dimensional echocardiography, ultrasonogram to guide fluid management, and coronary angiography. Treatment and management of cardiogenic shock. It is an emergency requiring immediate resuscitative therapy before the irreversible damage of vital organs. Rapid diagnosis with prompt initiation of pharmacological therapy needed to maintain blood pressure and to maintain respiratory support, along with the reversal of underlying causes, plays a vital role in the prognosis of patients with cardiogenic shock. And early restoration of coronary blood flow is the most important intervention and is the standard therapy for patients with cardiogenic shock due to myocardial ischemia. Medical management. Goal is to restore cardiac output and prevent irreversible end organ damage rapidly. Fluid resuscitation strategy is a clinical challenge in the early management of cardiogenic shock as it is often difficult to assess and can vary over time. In case of hypovolemia, conservative boluses of crystalloids about 250 to 500 ml are reasonable while patient is being stabilized for cardiac catheterization. Oxygenation and ventilation. In that, oxygen goals vary depending on patient's comorbidities, but in the acute care setting, blood oxygen saturation of greater than 90% are acceptable. And low tidal volumes are used in the management of acute respiratory distress syndrome are considered lung protective and decreases the incidence of right ventricular failure. Low tidal volume optimizes blood flow between pulmonary and parenchymal vasculature. And the decrease in resistance in the pulmonary circuit lowers stress on the right ventricle compared with higher tidal volumes. Vasopressor support. It should be used to titrate a mean arterial pressure of greater than 65 millimeter of mercury. And vasopressin has lesser pulmonary vasoconstrictive effect than norepinephrine and may be more beneficial as a first-line vasopressor in patients with cardiogenic shock with acute right ventricular failure. Pulmonary vasoactivity can be modified by inodilators, phosphodiesterase 3 inhibitors, and nitric oxide. Continuous renal replacement therapy, it should be considered in patients with stage 2 kidney injury as defined by elevated serum creatinine level and urine output of less than 0.5 ml per kg per hour for greater than or equal to 12 hours, or when life-threatening changes in fluid, electrolyte and acid-base balance precipitates the need for dialysis. Hemodynamic monitoring. It should be focused on hemodynamic modification to produce stable vital sign and adequate tissue perfusion. Continuous blood pressure monitoring with an arterial line, continuous pulse oximetry, temperature, respiratory rate, and urine output are rudimentary parameters to monitor. Mechanical circulatory support devices, which offers significant advantages over vasopressor therapy, including substantial cardiovascular support without increased risk of myocardial ischemia and possible decreased myocardial oxygen demand. Options for acute percutaneous mechanical circulatory support devices are intra-aortic balloon pump, left atrial to femoral arterial ventricular assisting devices, and venous arterial extracorporeal membrane oxygenation. Percutaneous coronary intervention strategy. Coronary perfusion is an essential therapeutic intervention for patients with acute coronary syndrome complicated by cardiogenic shock. And last one is the schematic representation of a proposed pathway for cardiogenic shock management, which includes identification and classification of shock state, stabilization, followed by coronary revascularization in case of acute MI with cardiogenic shock, and comprehensive hemodynamic assessment leads to early selective tailored circulatory support and multidisciplinary cardiac ICU care. So thanks.
Very good. You can take, you have taken the clue from the girls who presented last week and made a very nice presentation to compete with them. What about thrombolysis? You have not mentioned anything about thrombolysis in this cardiogenic shock.
Yes, sir.
Okay, right. Whatever you have said is all very valid points, but in cardiogenic shock, the primary failure is with the heart.
Yes,
Okay, so we
yes,
have to restore the heart's function as early as possible to prevent not only permanent damage to the other organs which you mentioned, but primary aim is to restore the heart to its original function. That is the most important thing that you have to stress in this answer. So without wasting time, I'll just go to show a presentation for you. It
yes.
has the more or less the same points.